Ankit. Okay.
Okay. Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present No Thrombosis Live Inbox, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected course director, Dr. C.B. Keshamurthy sir. Sir is Chief Consultant Interventional Cardiologist and HOD at Manipal Hospital, Mysore. Past President CSI Mysore chapter. Sir did pioneering work in primary angioplasty at Mysore. Sir established interventional cardiology centers at Salem and Erode, Tamil Nadu. Sir has several national and few international publications and presentations to his credit. Sir also has teaching experience as DNB teacher at Vikram Hospital, Mysore. Sir is principal investigator for landmark trials Rocket AF, Reduce It, Credence, and Horizon trial, and 33 other national clinical trials and HST participation as primary and co-investigator. Thank you, sir, for your continued guidance and support for running this program successfully. Our distinguished moderators, Dr. D. Ramesh sir and Dr. Ganesh Seth sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. It is an honor for me to introduce our distinguished moderators for today. Dr. D. Ramesh sir is Senior Consultant Cardiologist at Sri Jayadeva Institute of Cardiovascular Science and Research, Bangalore. Ex-Professor and HOD of Cardiology at Vaidehi Institute of Medical Science and Research Center, Bangalore. Sir held various posts in academic bodies, Vice President Cardiology Society of India, Bangalore, Governing Council Member, Indian College of Cardiology, Governing Council Member, CSI Bangalore Chapter, Secretary, Indian College of Cardiology between 2014 to 2017, member of various cardiology societies. Sir has various publications in reputed journals to his credit. Sir is also faculty at various cardiology conferences. Thank you, sir, for joining today's program. Let me have privilege to introduce our second moderator for today, Dr. Ganesh Seth sir. Sir is Senior Consultant Interventional Cardiologist at Medanta Heart Institute, Lucknow. Sir is Fellow of Asia Pacific Society of Interventional Cardiology, Fellow of Society for Cardiovascular Angiography and Interventions. He is topper in Rajasthan in All India DM-MCH entrance examinations in 2015. Certificate of Merit in Medicine, subject in MBBS. Sir is member of various national and international cardiology societies, attended various national and international conferences and workshops in cardiology. Dr. Ganesh Seth sir will be joining in 10 minutes due to some emergency case. I would also like to introduce and extend a warm welcome to our esteemed speakers for today. Dr. Avinash Kumar Singh sir is Senior Consultant Interventional Cardiologist at Medanta Heart Institute, Lucknow. And the topic he is presenting today, the case is complex CTO intervention, bailout when rota fails. Thank you, Dr. A.K. Singh sir, for accepting our invitation to present the case. Let me have honor to introduce our second speaker for today, Dr. Venkatesh TK sir. Sir is Senior Consultant Interventional Cardiologist at Apollo Hospital, Jayanagar, Bangalore. Case he is presenting today is low contrast PCI. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is really an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our respected course director, Dr. Keshamurthy sir. The meeting will proceed further with the case presentation by Dr. A.K. Singh sir. Following this, we'll have discussion on the first case where all the faculty members will participate. Second case will be presented by Dr. Venkatesh TK sir. Following this, we'll have discussion on the case where all the faculty members will participate. Post the discussion of all the cases, we'll have the concluding remarks by our respected course director. I request audience to post their questions in the comment box so that we can take up those questions in the end. Without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. I request esteemed course director, Dr. Keshamurthy sir, to share his opening remarks on today's topic. Over to you, sir.
Thank you, Dr. Rishikesh, for that wonderful introduction. And I extend on my behalf a warm welcome to you all. I'm fortunate to be here with such an eminent panel of moderators, my co-moderators, and two very eminent speakers who will present their cases today. And thanks to Emcure for bringing us all together to this wonderful platform where there is an exchange of ideas and a lot of learning. I'm also a learner and a participant in this rather than a course director. That I would like to make it clear at the beginning. So without much ado, we'll embark on the first case presentation. The first case presenter is Dr. Avinash Kumar Singh. I invite him to present his case of chronic total occlusion, a balloon uncrossable lesion. Once you have crossed, there is a dilemma when nothing else can cross that lesion. We'll have a discussion later, but I now invite him to continue with this case presentation.
Thank you, sir, and good evening, everyone. So I will be presenting a case which we did a couple of months ago, and though it looks like a simple case, but we were in soup when our hardened devices were not helping us. So this is my case summary. So 61-year-old male, he has a background history of diabetes and hypertension, and he presented to us with the class 2 angina from last 1 year, and it progressed to class 3 even on maximal anti-anginal therapy. ECG was not showing any significant abnormality, and 2D echocardiography, it was showing no RWMA, ejection fraction was 55%. So with this information, patient was considered radial angiogram, right? You can see in mid RCA, there was moderate stenosis, and in left system injection and osteoproximal segment of LCX, there was again moderate disease, 50 to 60% disease. But you can appreciate there is a 100% occlusion at the mid segment of LED, and it looks like a calcific one. So this was the angiogram, and based on angiogram, we decided to go for PCI to LED, followed by staged symptom guided PCI to RC analysis if it is required. So our plan was to go for PCI to LED. We counseled the patient and considered this patient for PCI. So this was the LED CTO morphology. You can appreciate there is a blend in tree shape, and calcific proximal cap with two side branch, one diagonal. You can appreciate there was almost 80 to 90% disease in that, and there was large septal branch coming out from that proximal segment of the CTO. So angulation, there was angulation, S-shaped angulation, that was also challenging for us to negotiate the balloon, and the length was almost 20 millimeter. So JCTO score of this lesion was 3. So we started with right radiofemoral axis. We started with antegrade approach, and we took 7 French sheath, 7 French EBU guide through femoral artery, right femoral artery, and we took guiding injection from the right to radial artery. Initially, we took cyan blue wire in fine cross to take the feel of that proximal cap, and then we escalated the wire to fielder XT in a fine cross. We did multiple attempts, but we were not able to negotiate the lesion with this wire. So finally, we took Gaia 2 wire, and after multiple attempts, under the guidance from the retrograde channel, we were able to negotiate the lesion, and we parked the Gaia 2 wire distally. Then we took with the help of micro catheter, we exchanged the wire to the workhouse wire, and after that we did multiple balloon dilatation with semi-compliant balloon 1.5 to 2.5, but after multiple attempt we were not able to properly dilate the lesion. So we tried NC balloon, but it was not able to negotiate the lesion. So at this point of time, we decided we should go for rotablation. So we started with 1.5 burr, and we tried to modify the proximal cap, but that 1.5 burr was not able to negotiate the lesion. So we downgraded the size of burr, did multiple attempts. Again, we were not able to cross the lesion properly with this burr, but with multiple attempts, there was some modification at the proximal cap by this rota burr. So we tried again. When we were not able to negotiate the lesion with even a small size burr, so we were really in problem. We tried to use NC balloon again because we thought there was some modification at the proximal cap by rota, but we were not able to succeed. We did not able to succeed to cross the lesion. So we started thinking what was the problem, why we were not able to negotiate the lesion. So there was an issue of guide support and there was an issue of angulation. So so we thought we can use this anchor balloon technique, and it is going to help us in providing guide support as well as pushability, and it is going to decrease angulation, which is S-shaped angulation. So we want to tackle all the three problems which were there in during the process of this negotiation of proximal segment of the CTO. So with after putting anchor balloon in the septal branch, because luckily we have septal branch at the proximal cap, so we put an anchor balloon. At this time, we were able to negotiate the NC balloon. We dilated the lesion properly, and after that we deployed stent 3 into 24 at 12 atmospheric pressure. Then we did balloon dilatation for proper stent optimization. And this is the final result we achieved after doing this much of activity. So this was the final result we achieved. So patient was shifted back to CCU and discharged after 48 hours. At 4 weeks of follow, patient was stable, angina-free. So take home message from this case was balloon undilatable CTOs. They represent almost 10 to 11% of all CTO cases, and their intervention require algorithmic approach. Choice of hardware is one of the important steps of successful procedure. And the most important thing is patience, because in these kind of situations, sometimes we at one point of time we were thinking we should stop, but with the handy technique of anchor balloon, we were able to perform this case successfully. Sometimes easy looking lesions, they can be deceptive, and when high-end hardwares are not effective, then we can use our mind and basics of guide support. It is going to give us success like what we have achieved in this patient. So this is all from my case. Over to you, sir.
Thank you for that excellent presentation and how you overcame the challenges step by step and very elegantly demonstrated how a change in strategy helped you to. You want to say something more? You want to talk about that algorithm of balloon undilatable lesions?
Sir, actually, I'm not able to hear, sir. Please, sir, again ask the question. What?
Yeah, that algorithm, you want to present it again? That approach to balloon?
Yeah, sir. So in case of balloon uncrossable lesions, sir, again, the most important thing is support of guide. The support is important, and we have active and passive supports, and we can use, sir, extensions. We can use the second step is, sir, plaque modification. And for that, we can use these rota ablation and the granuloplasty, and all these things we can use it. So the two important thing we used to do in patients of a CTO with balloon uncrossable lesion, sir, we used to increase guide support, and we used to second step is lesion modification, sir.
Right. Excellent. You have another slide? Yeah, this one.
This is another slide, sir, for balloon undilatable, because our region was balloon undilatable region. Again, sir, we need to see the problem, and like in our case, there was three problem. One was the angulation, calcification, and the third important thing was there was lesser guide supports. So, sir, in that case, we need to increase the guide support by either by using guideline extensions, or by using anchor balloon techniques, or by putting wires in its side branch. So these things are going to give you good support, and you can at least try to push your balloon at the proximal segment of the CTO. Sir, if that problem of hard plaque is there we can use laser modification again by rotablation, by laser atherectomies, all these things we can do. Orbital atherectomy we can do. So, sir, so again, same thing is there. We need to increase the support of guide, and we need to increase the pushability by using all these techniques, sir.
Right. Do you think an imaging data would have crossed once you are dilated with a 1.5 or a 2 millimeter balloon, and that would have helped you to understand the lesion better?
Sir, initially we started with 1.5 burr, sir. Sir, but it was not able to cross, sir. So there was a problem also if we use a smaller size balloon burr. Sir, there are issues of sir, stuck burr. So that is why we did 3-4 attempts, but after that we removed the 1.25 rotor burr, sir.
Excellent, excellent. I now invite my co-moderators, Dr. Venkatesh, to make comments.
Hello.
Dr. D. Ramesh, Dr. Venkatesh.
Okay. Can I? Can I?
Yeah,
Can I come in? Yeah. Okay. Now we had one case like this where we did what is known as granuloplasty. Took about 1.25 mg balloon. It went in easily. Then we burst that. So the passage was created. Then we could easily pass about 2 to 2.5 ml. Then we used a cutting balloon, about 2.5. So now cutting balloon is known as poor man's rota. So it just modified because it gives a cuts and causes the vessel to expand. So after that we used a regular routine. So I think cutting balloon. If that is not possible, you can anyway you passed a wire. You could have passed another wire, or the another wire you could have passed that balloon. So it would have acted as a cutting balloon. Which,
Yes.
Right.
That would
These
have
are all
helped much
methods
further.
to
So
balloon uncrossability. So especially cutting balloons are useful in fibrotic hard lesions. But if there is a calcium nodule or something which is preventing the passage of any gear down,
this one is just to create a passage so that you can use either rota or you can use lithotripsy.
we have to use some kind of plaque modification.
Yeah, just to create a passage for the bigger equipment to pass on.
Absolutely.
Yes.
Dr. Venkatesh, you want to say something?
Yeah, I think that case was good. And like you said, Dr. Keshamurthy, I think it would have been good if the imaging was there because it would help us understand what's exactly going wrong. After your dilatation and you broke open the proximal cap, you could see that there was definitely an antegrade flow in the vessel.
Yes.
So after that, I would have probably thought if I could somehow get in some kind of an imaging tool, either an OCT or an IVUS, to understand what exactly was happening there. And it was a little surprising to see why the rotor was not going in. I can understand a 1.5 not going, but it perplexed me when I could see that even a 1.25 was not being going through that tight spot. So the option would be to take a cutting balloon at that point of time and nicely dilate it. And if required, I'm not sure, I didn't see too much of calcium also there. Actually, when I was looking at your angiogram, I don't know if I missed, but at that particular segment, I didn't see too much of calcium also. So could be a calcium spur or something hanging there. Imaging would have definitely contributed to an early success is what I feel.
Yes, sir.
More than the calcium or whatever, it was an abrupt bend in the vessel. That's why the rotor burr was not straightening that portion. In such a situation, orbital has some advantage. Orbital atherectomy has some advantage.
Definitely.
But like the speaker said, when you see a chronic total occlusion, never think of it as a simple lesion. So be prepared for all the upfront for all the obstacles. So you start with a long sheath and a appropriate sized guide because you want to take additional gear in. I would suggest you go femoral and go for a 7 French Amplats guide, which gives good support. If you find the guide backing off, immediately upgrade to a guide liner or whatever kind of additional guide support. Do not wait for something to be difficult and then do these things. In CTOs, you be upfront with your strategies so that things go on smoothly. Yeah. And then because of that abrupt bend, this technique of trapping helped the side branch with the balloon inflated that helped you to cross the lesion and finally give a good successful result. So finally, when I summarize, I'll bring up all these points again. So if there are any further questions in the chat box, we can ask. Otherwise, we can go on to the next presentation.
Was a guideliner used, right?
So guideliner I didn't use it. I was thinking we should use it, but there was one septal branch, so I thought we can use that septal branch for anchor balloon. And after putting that anchor balloon in that branch, we were able to negotiate the lesion. Sir, initially, sir, NC balloon was not able to negotiate this lesion. So that was the problem. So that is why, because semi-compliant balloons, we were able to negotiate that semi-compliant balloon, but it was not able to dilate the lesion. Then we started using this NC balloon, but it was not able to negotiate the proximal cap.
Once you have opened that wire, you could have used Grand Slam or Iron Man, which would have given much support for that. You should have this one straightened out the torture. Grand Slam would have been better, over which you could have taken the equipment down. Huh?
Okay, sir.
Yeah, the CTO guide wires, you got to put a microcatheter quickly in and change over to our regular wires at least, because these CTO wires are good to penetrate, but they don't give you much support.
Yeah.
So you should probably be, even many a times we see when you change over the CTO wire to a BMW or even, some conventional, whatever workhorse wires you have, they give you more support.
But here there was a bend. I think Grand Slam would have straightened out. It would have given more support now.
So that we were, I told you, it was a S-shaped bend, sir. So that is why we were not able to properly penetrate the proximal cap, sir.
No, after using that your Gaia 2 wire,
you
could have changed over to Grand Slam, which would have helped you in two ways. One, straightening out the angulation, and secondly, it would have given a better support for your equipment to go down. So anchoring would have been avoided.
Okay, sir. Thank you.
So after you changed over to a rota wire, what did you do exactly? You pulled out the rota wire and rewired it again for a regular wire, or carried on with the rota wire?
No, sir. We use a regular wires.
Okay.
Yeah.
Okay.
Any questions in the chat box, Dr. Rishikesh?
No, sir. So far, there are no questions.
Okay.
So we can move to second case. And
So we can
Dr. Ganesh Seth, who is our second moderator for today,
welcome, Dr. Ganesh Seth.
Welcome, Dr. Ganesh.
Thank you, sir. Thank you.
Sir, your comments, sir. We would love to hear your comments on this case.
Sir, I haven't seen this case, so I would not be able to comment.
Okay. Now I invite Dr. Venkatesh PK, very eminent and senior cardiologist from Apollo Hospital, Bangalore, to present his case.
Thank you. And I think my slides are visible.
Yes, sir.
Yes,
requesting you to make it full screen.
Right.
Full screen.
Is it full screen now?
Yeah.
Yes, sir.
And are my slides moving?
Yeah.
Yes.
Yeah.
Thank you. So today's basic presentation will be on low contrast PCI, because we are all confronted many a times with patients whose creatinine is on the higher side, and we defer doing angioplasties. And many of them do not get the benefit of angioplasty either because of the fear from the doctor's side, or because of the fear from the patient side, or because the nephrologist says, no, you can't do it. The creatinine is quite high and all that. So we need to devise a way out of this problem. And one of the solutions we have is something called as a low contrast PCI. So let's go ahead with a case presentation showing what is a low contrast PCI. This is a 70-year-old female with an acute coronary syndrome manifesting as NSTEMI, sinus rhythm with an ejection fraction of 40%, and presented with acute pulmonary edema, but then slowly recovering because of medications and diuretics and whatnot. And the problem was an ongoing chest pain with a comorbidity of diabetes, hypertension, and CKD. So with this background, we proceeded to go ahead with the angiogram. And this is what the angiogram showed. So you can see at the bottom of the slide that the right coronary artery is looking good. And if you look at the left anterior, left elevocranial, you can see that there's almost a subtotal occlusion of the left anterior descending artery. And the circumflex also on the caudal view is again some kind of a subtotal occlusion, and you can see a TIMI 2 flow going on there. So with this picture, we thought that we will open the the LAD, and what we thought was we'll just go initially and pre-dilate with a 220 balloon, a long balloon, so that we could establish some kind of flow there, which would help us to take some imaging equipments inside. And rightly so, we went in after dilating the tight lesion and put in an IVUS catheter. Otherwise, the IVUS catheter would not go when you have such tight lesions. So this is the IVUS run from distal to proximal. You can see here, as we come along, that distally also there is a lot of diffuse disease. And then comes this good-looking thing. This is actually a myocardial bridging. So you can see the myocardial bridging on the IVUS run beautifully. And as we come a little proximally, the lesion gets tighter and the MLA really goes down. And then subsequently, proximally, you try to get a proximal nice landing zone. So without wasting much time, I'll just show you what we have. We have the proximal landing zone, which is, of course, showing a minor disease. And it's got a good MLA, 6.2. And when you look at the tightest spot, it's got an MLA of 1.94, and the distal landing zone is showing about 3.57. It's not a very great distal landing zone, but still probably a residual disease there, but still something to go by. So the distal LAD was dilated with a 220 balloon post IVUS, because we did find that there was a lot of disease there. And then after dilating, we again went in with the IVUS catheter, and we find that there is a minute dissection near the distal landing zone, but that was very small. We were not really very worried about that. And then, of course, we took a stent, and the beauty of this was that there was a diagonal wire which we had put. So when we put a diagonal wire, we know where to start the stent from. So let me go back. When you run here, the proximal, when you run this, you can clearly see that we have a diagonal wire here as a marker of our proximal landing zone. Can we see that? So this will serve as an important tool for us. We don't have to give injections. So we use this diagonal wire as our marker. And we took a 2.75 to 24 synergy, and then we inflated this stent, implanted the stent. The proximal edge was looking good. And there was a little bit of an underexpansion in the mid part, giving us an MLA of 2.6. And of course, the distal edge dissection, which was there, became a little more, but nothing to get really worried about. And we optimized it with a 3 into 12 mm balloon. The underexpanded stent was nicely dilated, and post IVUS, you could see that the stent is well expanded. And then we could not leave the distal LAD as it is, because that was all a diseased vessel, as you saw in the IVUS. So we took a drug-eluting balloon, 2.5 to 30, and just from the place where the stent overlaps, we took it and dilated it, and treated the vessel with a drug-eluting balloon. This is the drug-eluting balloon. And this is the post-DEB stent, no dissections, it's looking good. And then once we finished with the LAD, we had to look for the circumflex. What we did was we wired the circumflex, but all the time, because of the tight occlusion in the proximal part, our intent was to get into the OM. But here you can see that the wire was all the time going into the distal circumflex. However, what we did was we took a balloon and then we dilated with a 1.5 into 15. We allowed the wire to get into the distal circumflex, but we took a balloon which was 1.5 into 15 and modified that lesion. Once we modified that lesion, we find that it allows our wire to get into the OM very easily, which we could not earlier. So this gave us space to get into the OM. So then, of course, we run the IVUS. You could see the nodular calcium in the IVUS, and this nodular calcium was from the OM to LCX, because we did this run from the OM to LCX. So you can see that there is a nodular calcium there, but it didn't put us off. What we did was, again, we had to minimize the contrast. The creatinine was high in this patient. So what we did was we marked the proximal landing zone with an IVUS catheter. We took that as a roadmap. And then we positioned the stent, a 2.5 into 28 stent from the proximal landing zone across the circumflex, distal circumflex, into the OM. And then we optimized it with a 2.512 and a 2.75 balloon. And then we did some post IVUS imaging, which showed us that we really had some good results, and the MSA achieved was 4.6. So this was the final shot, and you can see here that the circumflex is nicely open, and then we have the LAD there nicely stented, and we have a good result coming out. So the indication for PCI, once the eGFR is less than 30, or the serum creatinine is more than 1.5, or eGFR is less than 45, then we also have to consider some clinical factors like age more than 75 years, ejection fraction less than 35, diabetes, recent hypertension or shock. And we always have to offer these patients a low contrast PCI or ultra low contrast angiogram followed by absolute zero contrast PCI, and then try to revascularize the vessel, because any contrast that you give many a times will lead to worsening of renal function and the patient going in for dialysis. So here in this case, whatever we could manage, we used, including the angiogram. The total contrast usage was about 50 ml, and post-procedure, the serum creatinine was about 1.6, and the patient even today is doing well without any need for dialysis. Then I go on to the second case, a 70-year-old male with effort angina class 3, sinus rhythm, preserved LV, diabetes CKD with serum creatinine of 2 on medical management, and he's morbidly scared of dialysis. And this was a patient who underwent a PTCA to RCA 5 years back. So this is the angiogram that you can see. The left system is okay. Distal circumflex is all diffusely diseased. We don't want to do anything there. But then if you look at the RCA, which is almost like a super dominant vessel, you can see here that it's all calcified, corrugated, and it's got diffuse disease. So what we do is we look at the IVUS runs. In the proximal RCA, you got a 360-degree calcium there. In the mid RCA, again, there's also a lot of heavy calcium, and you can see that the MLA is about 3.3, and the distal RCA seems to be, again, showing calcification, but the luminal diameter is about 8.06. So we went ahead and pre-dilated with 3 into 10 NC in the mid to distal part, and then, of course, we used a cutting balloon. And after that, we dilated it with a OPN-NC balloon. So because that dilatation did not give us a satisfied result, so we did this with a OPN-NC balloon, which was 3 into 10. And then when we looked at the IVUS after modifying the lesion, we did see that there was a lot of cracks in the calcium once we nicely prepared the bed. So once cracks appear in the calcium, it means that our stent is going to yield because they have given way. So these are the cracks that you can see. So this again, we did a pre-dilatation with OPN-NC balloon. Sorry, that was a repeat slide. And then the distal landing zone in IVUS was identified, and it was showing there a diameter of 7.21. And IVUS catheter again was used as a distal marker. We wanted to use a roadmap And we did use that this particular place in IVUS, was road mapped. And we wanted to make sure that the distal part of the stent ends there. So we used that as a roadmap, and we took a 3.5 into 48 DES from mid to distal. And of course, the remaining part, the proximal, was covered with a 3.5 into 32. So this became a metal jacket. And then the convention follows post-dilatation with 3.5 into 12 mm NC balloon. And post-stenting, you can see the IVUS run. We've got some fantastic result here. Proximal edge, no dissection. Mean SA, there is a mean stented area 7.96. Distal edge, again, no dissection. So we got an excellent result. And again, mid-stent, if you could see, we were still not very happy with the 7.96. So we went ahead in the mid part and nicely dilated it. And this was the post-optimization IVUS. It gave us a mean stent area of 8.2, which was very good. And we were quite happy with it. Although even the previous one was also okay, but we could see that a few struts were completely not opposed. So this was the final shoot, nicely reconstructed RCA. Of course, it's become a metal jacket now. PD and PLVB are going fine. I think I'll show you this last case, 44-year-old female patient. Look at the age. And chest discomfort on exertion from 2 days, ECG hyperacute anterior wall myocardial infarction. And she is interestingly a known case of primary pulmonary hypertension with a PSP of 120 millimeters of mercury. Echo showed preserved LV function, severe pH, and normal RV function. So whenever we have a severe pulmonary hypertension, it's very easy for us to probably attribute chest discomfort to RV angina. But then when you're confronted with an ECG which shows hyperacute anterior wall MI, everybody wakes up. Of course, the preserved LV function and severe PAH. And this is the coronary angiogram. You can see here the right coronary artery looks good. But then look at the left main, the ostial left main, probably another view. Look at that. Yeah, the ostial left main is very tight. So we decided unconventionally to do a saline OCT in this patient. We did a OCT and we did a saline OCT here. And you can see here that when you look at the images, as we come from distal to proximal, that's the diagonal taking off. That's the left main. And as you come down, you can see here, as we reach a long left main, and you can see here, it gets tight. That's the tightest portion. Yes. So we did a PCI 4 into 12 Zymes and post-dilated with the 4.5 into 8 NC balloon. And this is the result we got. You can see the dilatation happening. Wonderful result that we got. And post-OCT, of course, let me run that. Stent is well opposed. You can see the stent wonderfully opposed. Yeah, the stent struts are coming in. So you can see that there is no under expansion, no stent struts hanging anywhere. And that's the ostial. Very good, result. So this is the final result that we got. Beautiful result that we got. So this again is a repeat of the previous slide. And this is how we should probably be looking at whenever there's an indication for PCI. Look at the eGFR, look at the creatinine, look at the clinical profile of the patient, and of course, plan for an ultra low contrast or a no contrast. Intravascular imaging can effectively guide PCI and improve the results of stent deployment. IVUS guided absolute zero contrast PCI is feasible and safe in these high-risk patients, and even complex PCI can be performed successfully without major complication. Thank you very much. And with this, I end my presentation. I would also like to share that just about 2 days back, we did one more case of low contrast PCI. And this was a patient who presented with inferior wall myocardial infarction, underwent culprit region angioplasty 3 weeks ago. And then his inaugural creatinine when he presented to the hospital was 1.45, and it jumped to 2.2, and he went on having this creatinine of 2.2 over the period of next 2 to 3 weeks. But then he was being troubled by angina because he had a LAD and circumflex both sides lesions, which was pretty tight. So he had to have the PCI. So we talked to him about ultra low contrast PCI. And this time we took an IVUS help. What we did was we wired both the LAD and LCX and put our IVUS catheter into the LCX. And after doing a LAD run IVUS, we knew from where to where the lesion extended. And it was osteoproximal LAD to extending to about 18 millimeters down before the first diagonal. So what we did was we put the IVUS catheter in the circumflex and looking upwards of the confluence under no contrast, there's absolutely no contrast. We just placed a stent under IVUS guidance in the osteoproximal LAD, and we deployed the stent, did the post dilatation, and probably we used just about 5 or maybe 10 ml of contrast, final shot, and got over the whole thing. And our road mapping of the IVUS catheter in the circumflex also, of course, circumflex was a very small discrete lesion. We didn't do too much on that. It was pretty straightforward because our IVUS catheter marking was also there. We just went and stented the circumflex lesion, and the results were extremely good. And the total amount of contrast, everything put together, was definitely not more than 15 ml. So I wish I had that case, but due to lack of time, I couldn't show that. That was also one other way which we did this low contrast PCI. Thank you, and over to the organizers. Thank you, sir. Over to you.
To Dr. Venkatesh for those expertly done cases. It highlighted your expertise in handling these high-risk and complex cases, and very intelligent use of imaging, especially IVUS, to reduce the contrast load, and very beautifully done, and in the end, a great result as usual in your cases. In the last case, do you think it's a kind of aorta arteritis? And what was the cause of the STEMI? Because we can't see any thrombus anywhere. Was it an additional spasm on that osteal lesion, or what caused the STEMI, ST elevations? What do you think?
Exactly. That's really a very good question. We were also really perplexed because we did not find any thrombus when we looked at it, the OCT. But definitely the osteal LAD lesion was very, very tight. So it is possible that this tight osteal LAD lesion could have also precipitated a transient spasm of the LAD and led to the osteal LMC lesion could have precipitated a tight spasm of the vessel and could have led to a myocardial infarction, because there was all the telltale signs. There was ECG, ST elevation, the cardiac enzymes were also up. But then when we did the OCT, when we were trying to look for any thrombus, we didn't really see there. And what we actually saw on the saline contrast was all swirls of blood, that's all. But there's no real actual red thrombus or any kind of thrombus that we could discern on the OCT. So most likely the explanation is by the time we went in and we did all this, a certain amount of spasm could have probably been relieved. But by then, to be honest with you, the patient continued to have chest pain. And I don't know if it was also the hypertrophied myocardium, the RV, which was also in some way contributing. The patient also had severe PAH. Maybe, I don't know if that was also putting that extra myocardial consumption demand and could have caused some kind of ST elevation on the ECG with the enzyme elevation.
Excellent. The second thing I would like to know is, was there any disease activity? Because when we treat these patients during acute disease activity, they seem to have slightly higher events. So if we have to do in an emergent situation, we follow them up and try to see their disease activity with CRP, ESR, and all the conventions, and try to...
Correct. That is what we did was we involved our hematologist actually for the thrombophilia screen, because she was very young. She was just 44-year-old. And normally it is a protocol here that whenever we have patients who are young and who present with myocardial infarction or NSTEMI, or we find a thrombus when we are doing any imaging, it becomes a part of a protocol to refer these cases to the hematologist, and they do this thrombophilia screen where they look at homocysteine, protein C deficiency, protein S deficiency, and they also, especially in females, look for antiphospholipid antibody syndrome. And then, of course, we also know that there's something called as a triple variant antiphospholipid antibody syndrome, which are being increasingly reported. So we look at all these things actually. And in this patient, rheumatologist also was actually involved to see if there was any contribution from connective tissue disorders. But nothing really, honestly, came out of the whole thing.
Right. Wonderful. Those were really great cases. And this concept of low contrast or ultra low contrast has been around for some time. In fact, even before imaging catheters were available, we used to be always aware of how to reduce the contrast. That awareness is very important. You don't keep on injecting and doing more injections. Do a precise job without much injections, especially in patients with borderline creatinine, those at-risk patients. So even in a normal PCI where creatinine is normal, you have to practice these techniques, and then only you will become an expert. Then you really have to save on contrast. Before the available of the IVUS catheter, we used to use the wire themselves as markers. We used to put a wire in the side branch, like you did in the first case. You put the wire in the diagonal. That itself acts as a marker, and keep that as the center, and see the lesion and implant a slightly longer stent maybe to cover the lesion and avoid missing it. And the second thing is use another second wire, the radio opaque portion, which is about 3 centimeters in most of the wires. Use that as a measurement so that you need not make additional injections. And once you place the stent using that, pull out the wire and then implant the stent. So many other techniques we have used. In large super dominant RCS, we have used a clot aspiration catheter and put it distally so that we can just induct a little bit of contrast to just see the lesion, then pull it back and do a stenting. So all these kind of techniques can be used. You have to be proactive in these situations. You cannot just give contrast and let the creatinine increase and then look back and see what could have been done. So these are very interesting lessons that we have learned today from imaging co-registration with IVUS and various other techniques, so elegantly demonstrated by Dr. Venkatesh. I now invite my co-moderator, Dr. D. Ramesh, and all the others to take part in the discussion. Dr. Ramesh, Dr. Ganesh said, please make your comments.
Sir, obviously it's a nice demonstration of the low contrast PCI. Sir, I want to ask why you took your wire back in the first case. Why you took your wire back from the distal LCX to push it in the OM?
No, it was not going. I didn't take it back. See, the problem was in the circumflex, the lesion was so tight. All the time the wire was going into the distal circumflex, but I had to go into the OM. So what I did was I just went into the distal LCX, then took a balloon and dilated the tight lesion which was proximal to the OM. That gave me the maneuverability to negotiate my wire into the OM. And you saw in my very next video how easily after I dilated with a 1.5 mm balloon, my wire could easily go into the OM. My wire was all the time going into the circumflex because that nodular calcium there, what was there exactly between the circumflex and the OM was a nodular calcium. It wouldn't permit the wire to get into the OM easily. That was we were also wondering why am I not able to get my wire into the OM all the time going into the distal circumflex.
Then after dilation, you again if I would have done that case, then I would have placed the second wire in the OM rather than
no, I went into the OM. I don't need a second wire. The same wire I pulled back because there is no lesion to stent in the distal circumflex.
And then you took 2 wires in the OM as well as distal LCX while placing the stent.
No.
2 wires.
No, I don't want to do anything in the distal circumflex. I dilated the proximal circumflex. My stent is from proximal circumflex to OM. Distal circumflex, I'm not doing anything there.
Yes.
I'm not doing anything to distal circumflex. I am interested in the lesion in the proximal circumflex going into the major OM. I don't have anything, no lesion there in distal circumflex to touch. But the problem was my wire was all the time going into the distal circumflex. So to make my wire get into the OM, I dilated the lesion with a balloon, and that gave me a little more maneuverability to take my wire down into the OM. That's how it is. And I stented it from the proximal circumflex to the OM. That's what happened.
Yeah, many a times the proximal plaque modification helps you to
negotiate the wire, obviously.
Yeah. Any other comments?
Sir, Ramesh sir, you are on mute.
Dr. Ramesh is on mute, I think.
Yeah, now I'm audible.
Now you are audible.
Yes, you are audible.
Referring to Ganesh, instead of dilating it, there's one thing known as blocking technique. The wire which has already gone into the distal LCX, you could have put a balloon over that and taken a second wire. You would have deflected into the OM without dilating the lesion. Because sometimes what happens, When you dilate, you may cause dissection, which may extend either proximally or to the distally. Then you are in the dilemma. Instead of putting one stent, you have to put two. So what you can do is pass a wire to the distal LCX where it went, wherever it goes. Take a small balloon, 1.5 ml, just slightly inflate it to block it. Then pass another wire. When it hits that inflated balloon, it gets deflected into that particular region. This is not blocking belt technique. Or you what is known as reverse wiring. You bend the wire to bend the wire on that. So you make a U wire. Then when you're coming from the distal LCX, just pass to where it will just get into that. So there, this is known as reverse wiring or a block technique. And coming to your second question, that what Keshumurthy was referring, that osteal lesion. You said that despite there's no lesion, could it be a myocardial infarction with non-obstructive coronary artery disease? Where
But we did yeah, correct. But you
yeah,
can't label it that. Here is an obstruction which we demonstrated on the OCT.
because there's a lesion there. You already demonstrated lesion, but the flow was almost TB3 and there was no
But
thrombus.
then, no, but the definition of Minoka is you should make sure there is no obstruction. There is an obstruction here. It doesn't classify as Minoka.
No or minimal obstruction. No or minimal obstruction less
But
than
this is
70%.
not minimal. This is very tight,
I
osteal,
know, I
almost
understand because
90%.
osteal left main, I understood your stenting. And the second thing was the you did think of I think there's one more like when you have this one PCI with serum creatinine like this, carbon dioxide angiogram is coming into vogue. In the Western world, they
Yeah,
use
but we are
carbon
not,
dioxide.
I'm not
Carbon
using
dioxide.
it. They are more, now the carbon dioxide angiograms are used more in peripheral vascular disease by our vascular
But it is
surgeons.
used in coronaries also. We started
Yeah.
with peripheral. Now it has come to coronaries. I attended one session where they did a carbon dioxide angiogram and angioplasty, and it is very good. Only thing is you should see that the carbon dioxide given is not more than 50 ml. Otherwise, it causes a blood-brain carrier and causes carbon dioxide paresthesia. But I think that will become a big thing in the near future. Thank you.
Any other questions in the chat box?
So I have one query. While performing this ultra low contrast PCI, so when that minimal amount of contrast you used to inject after placing the stent or before deploying the stent, you give that small amount of contrast, sir?
No, sir. While before deploying the stent or after deploying the stent, no contrast is used. We make use of imaging. We make use of imaging. We make use of certain roadmaps. We put it at the IVUS catheter itself is used as a roadmap. We take the IVUS catheter, we know where the lesion starts. So we roadmap there. We know the proximal, we know the distal. Sometimes we also roadmap with respect to the wire, as is shown in my first case. You have the diagonal wire coming out. So these help us to precisely place the stent. I wish I could have shown you the case that we did 3 days back, where we had our IVUS in the circumflex and we were positioning the stent in the osteoproximal LAD. It was a beautiful case. I could not get those CDs in time. Otherwise, I would have shown. We just did not use any contrast before deployment. After deployment, we always do an IVUS run. So you will get to know if there's any distal edge dissection, proximal edge dissection, under expanded stent, anything that happens inside, we will get to know. So in this manner, we try to, as much as possible, minimize the use of contrast.
In fact, the newer machines, cath lab machines, are coming with the co-registration, imaging co-registration, as well as the angiographic co-registration that can help in reducing the contrast value.
100%. 100%. They are all our tools to minimize
yes
contrast usage. Yeah, definitely.
If we don't have any anatomical landmark for proximal segment, so in that case we are not going to use any
No, our IVUS marker is always, because you see the lesion, right? When you do an IVUS, you know the extent of lesion, you know where to end your stent. Mark it there.
Okay.
That will be a roadmap.
IVUS is pretty accurate with respect to proximal landing zone, distal landing zone, length of the lesion.
You can easily mark your zones, where exactly, how much is the length of your stent, where to where you want to go. It gives us the complete picture.
Right. Thank you all for the wonderful comments. And since it was supposed to be a CTO
This
session,
is one last question. You
Yeah.
think this low cost PCA should be done when the creatinine is 1.5? Normally we do when it is more than 2.5 or more than 2.5.
Not necessarily, sir. I think you
I
should
think,
practice in every case. Even
yeah,
in the creatinine is normal, you should practice a low contrast. That's how you learn when you get into challenging cases to reduce the total amount of contrast. So contrast is always,
completely
you do
agree.
not know which patient will develop contrast-induced nephropathy. You think a diabetic patient who is dehydrated near normal creatinine, but they can develop some contrast-induced nephropathy. So be careful in every case. Be stingy with contrast. That's what I advise all the people.
I agree. I believe the comorbidities also dictate the contrast volume. The
Absolutely.
diabetes, the hypertension. Then again, you should use the low contrast as much
Yeah.
as possible.
Yeah, make the minimum number of injections. Many times we think we'll profile the lesion, look at things and all that. Many times it is imaginary. And now with imaging coming in, you don't require so many angiograms at all. So those are my thoughts about reducing the contrast. So since I
Excellent.
think we are nearing the 9 o'clock mark, but I'll just take 2 minutes and show about 3-4 slides because it was supposed to be a CTO session. With the permission of my co-moderators, just a few things about what I thought is important in chronic total occlusions. Many people in whatever field they are expert, they call it as a final frontier. People say peripheral interventions, aortic interventions are final frontier, CTOs are final frontier. Nothing is a final frontier. Finally, when you are challenged by a complexity or a difficult situation, that is your final frontier, and you have to devise your own mechanisms. In fact, Theodore Roosevelt has once said, wherever you are with whatever you have, do the best thing that you can. Do not think that some device will come and rescue me, or I'll get something better and all that. Stop that mentality. Just do what best you can in the geographical location where you are with whatever resources you have. And that is the kind of philosophy I've been working with it. So why is CTO called as a final frontier? Of course, the procedures are challenging because the vessels have been occluded for a long time. They are hard, difficult to cross. The anatomy has been difficult. Many of the times, these lesions have been tried elsewhere and failed procedures. The time and effort required is quite tremendous as compared to a routine, say, primary PCI, which you can finish in 5 or 10 minutes. A CTO is more a planned, time-consuming, effort-consuming, back-breaking effort. So that's why maybe it is called as the final frontier. We cannot discount the radiation exposure, an extremely important part of the life of an interventional cardiologist. When we get on to some 10, 15, 20 years of practice, you will realize that radiation will certainly have effects on many of us, and that is the reality. Irrespective of what protection you use and the procedures you do will ultimately have a telltale effect on every one of us. Just as we discussed, the amount of contrast is sometimes a limiting factor in chronic total occlusions. Always be aware of the contrast. Upfront, if you start saving, when you get to the limit, you will have some limit so that you can complete that procedure successfully. Hardware is another extremely important thing in CTOs because many of the times when we fail, when we take up CTOs and think we can get over it, we realize that some wire is missing in our portfolio, or when there is a complication, we suddenly find that we don't have the right type of covered stent or a coil or a gel foam or whatever is there. So extremely important to set your eyes on the hardware box and keep everything available for a successful outcome. The expense. Many a time, a simple angioplasty, you can get away with a cost which is planned. Whereas in a CTO, when you ask for more and more wires, escalate the equipment, use imaging, use additional tools to get across, do additional plaque modification, do rotablation, calcium treatment, the expense becomes tremendous. So this is one thing you cannot completely plan for. Many a time you would have counseled the patient for 2 or 3 things, but ultimately the expense would have outrun everything because you would have started with one workhorse wire and one CTO wire. But finally, when you see your CAT table, you would have used something like 6 or 8 wires or 10 wires because you just want to get across and complete the procedure successfully. Of course, complications is one thing you cannot anticipate completely, though you are always on the lookout for that, always at the back of your mind. In a chronic total occlusions, complications is always there. but they suddenly appear and you have to have your way of dealing with them. Go by protocol. Whenever there is a, say, a pericardial effusion or a perforation, type 3 perforation, stepwise you go about it, then you can salvage the patient can be salvaged. Coping with unsuccessful revascularization, physically, mentally, this is very challenging. You have spent some 3 or 4 hours in the cath lab with about 120 minutes of radiation. You are fully zoned out, and then you come out and tell the patient attendants on the face that despite our attempt, it was unsuccessful. So much money has been spent, but we were unable to treat the lesion successfully, because for us as cardiologists, it is a different measure. But for the patient, success or unsuccessful procedure means completely different things. So coping with this is one thing which we have to learn and practice in our minds and be ready with the right kind of solutions. So what are the key steps to success? Planning, planning, and more planning. CTOs are not ad hoc procedures. Sometimes we are forced to take up CTOs in ACS, or sometimes, very rarely, even in an acute MI, you can be confronted with a CTO. But apart from that, it has to be a planned procedure. You have to plan the appropriate timing. You have to plan, image them previously, do a CT maybe. I'm not very fond of CT, but CT is supposed to help a lot as per the Japanese operators to understand the morphology of the lesion and everything, the hardware, the anticipated complications, the time, even your OPD, for example. What puts pressure on you in a CTO is that you are not got out of the cath lab in 60 minutes or 1.5 hours. You keep getting calls from the outpatient to see patients who are waiting outside. So these kind of situations put an indirect pressure. Though you go on, complete the procedure, there is a kind of a subtle irritation which comes in because of these things. So really plan these procedures in the early morning when you are really fresh in the mind and in the body, not when at the end of the day when you are fully tired and you just want to get on with this case. Please plan your CTOs in a proper manner. About the indication, I know as interventional cardiologists, we are absolutely sure that this patient will benefit with a certain procedure before embarking on that. But in a CTO, make doubly sure. Have an imaging modality to support you. Do have a myocardial perfusion scan or something which supports the indication for really opening this CTOs. Because if you see all the randomized trials of CTOs, some of them have come as negative because they were taken up without enough imaging evidence, or the volume of myocardium that really benefited was low. So in those studies, there was no mortality benefit despite so much effort. So be doubly sure or maybe triply sure before you embark on a CTO procedure. Pre-procedure counseling, sit across, explain to the patient's relatives what is being planned and what are the difficulties anticipated, the possibility of success in your center. Of course, about 50 to 80%, you have to give a realistic figure for the patient. What are the alternatives? And in case of a complication, these are all the things that have to be discussed with the attendants upfront. Assemble the appropriate gear, as I mentioned in the previous thing. As far as possible, your toolkit, CTO toolkit should be, each and every center can have everything, kind of different wires, but at least have one of them, one long wire, for example, a 300 centimeter wire to exteriorize, of course, the microcatheters and those sort of things I'll mention in the next slide. And be prepared for events like an arrhythmia or a cardiac arrest or rupture or a type 3 perforation. And so that you can do everything stepwise. And the team aware applications and protocol driven handling really saves patients in such situations. What are the CTO toolkit? Like we discussed in the first case, guide catheters, the access sheets, the guide extensions, extremely important. Do not ignore this fact. Do not try and selectively take up a case and whatever guide is given by the technician, don't go with that. You have a clear-cut idea of what guide you are going to use. And in case that doesn't engage well, what is the next plan B or plan C? And then a guide extension up front, a long sheath up front, a good access size guide catheter. Suppose you're stuck with a 6 French guide and you want to take an additional device, there is no room for that. If you put a 6 French guide catheter and take a guide extension, if you want to put a second wire or a third wire, there is no space for that. So then you are really stuck because you are crossed with a wire, then you have to pull out the guide and take access with another guide. So all these things have to be anticipatory rather than looking at things when the problem occurs. So you have one workhorse guide wire which you are very familiar with, and a dedicated, of course, there is a basket of dedicated CTO wires, but get familiar with a few of them. Why I say this is because if your favorite wire is, say, a penetrative, moderate penetrative wire, go with that. Do not go with what is shown in the conferences, because even with Gaia, like we just discussed, Gaia 3 or Gaia Next wires, in the learning curve, 4 out of 10 times you end up in the subintimal space when you start off with a Gaia wire without enough experience with that. So get your adequate amount of cases through, then go with the really hard wires. Trapping balloons, be familiar with trapping balloons, be familiar with the distal anchoring or the proximal anchoring technique. Microcatheters form an important part of the arsenal. Imaging, wherever you can do, you have an imaging tool with you. Calcium treatment should be ready and available. Of course, hemodynamic support in cases where it is the single surviving vessel. CTO may be supplying collaterals to the other dominant vessel. In those cases, you have to be very careful about hemodynamic support. In cases where you have dual guides, in almost all the cases, we start off with a dual injection from the other side and approach from one side. And when you convert it into a retrograde approach or something and you dissect the donor vessel, then hemodynamic support becomes suddenly very important. So you have to be ready for that. And complications kit I already mentioned. So these are some thoughts about these things. Chronic total occlusion is a different ball game. So be prepared, be armed, and be alert, be forewarned. Then you will have a successful outcome. And acceptance of failure. There is always another day. Do not be driven by ego. When you cross the limit of, say, contrast and fluoroscopy time, and you are physically tired and you can do no more, accept that and get a patient safely, bail him out, and do an investment procedure, accept an investment procedure, and subsequent, there is always a day when you can come back with better gear and better cooperator or something, and then do a successful procedure, and then counsel the patient adequately. So these are some brief thoughts I thought I would share. I don't know how useful it was to all of you, but just from my experience, I thought I'll share a few of these points, especially for the youngsters in the audience. Thank you all for the patient listening, and thank you for the opportunity that you gave and listened to me patiently.
Excellent points, sir. Very good points.
Quite crisp and precise.
Yeah, thank you. Any other comments or anything in the chat box we want to discuss? Otherwise, we'll end the session. It was a great, wonderful session. And there are so many eminent speakers and co-moderators with me today that I learned a lot from this session, and from the cases presented by Dr. Venkatesh as well as Dr. Avinash were eye-openers.
I would like to express my sincere gratitude to our esteemed course director, Dr. C.B. Keshwamurthy sir, and our distinguished moderators, Dr. D. Ramesh sir and Dr. Ganesh Seth sir, for sharing their knowledge and expertise with us today. I would also like to thank Dr. Avinash Kumar Singh sir and Dr. Venkatesh TK sir for their insightful case presentations. Your contribution has undoubtedly expanded our understanding of about the cases discussed today. I would also like to thank our esteemed audience for their time, continued love and support for the No Thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing and medical team at Emcure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you very much. Thanks to one and all.
Thank you. Thanks, one and all.
Thank you,
Thank you,
Shruti.
sir.
Thank you, sir.
Thank you, Ramesh.
Thanks a lot. Good night.
Thank you. Thank you.